changer. Welcome. We're going to go through a series of slides, and you're going to get a recording of this anyway. I'm going to talk over the slides. There's quite a bit of photographic material for you to look at on the slides, examples of different postures and things like that. You might want to make a few extra notes because when it comes to which muscles are short or long or tight and that sort of thing, I am going to give you a couple of tips about that as I talk through the slides. And that information isn't all on the slides. Only because it would have made them very, very busy. So what are we going to cover? Well, hopefully you have an idea of what we're going to cover today, because that's why you've signed up for it. But just as a reminder, I'm going to talk about why should you do a postural assessment, which clients might benefit from the postural assessment, when should it be carried out? So what I mean by that is what time, you know, what the first time you see someone or 6 months down the line, you know, that kind of thing. How long should it actually take? And then, of course, the nuts and bolts of the whole webinar today. It's only 60 minutes, but I'm going to try and give you some really useful information about how you actually go away and carry out a postural assessment. So after today, after this 1 hour, you should be able to go away and put something into practice. Now, you might want to practice with some people first, but you'll have enough information to carry out a postural assessment. And what we're going to do is we're going to do it from a couple of different viewpoints. So, whoops, I've lost my cursor again. So the sorts of things you should look for from the back, the side and the front views. So we're going to look at all different sides of the body, and I'm going to give you some resources. One thing I want you to remember, and there was a little note about this when you signed up, that is today's webinar is about the assessment. It's not about correction. And I was just chatting to Heidi from the FHT about this. Unfortunately, postural correction is it's simple, it's straightforward, but there's an awful lot of it because obviously the body's complex and it's all joined together. And with the best will in the world, I can't teach postural assessment and correction in one webinar because it's just too much information to really focus just on the assessment. And it's not that, yes, we want you to sign up for another webinar about postural correction. It's just there really is so much information. And if I could do it, I promise you, I certainly would. So what are we going to focus on? I'm going to obviously focus on how you actually do the assessment. What I'm not going to do today is talk about the arguments for and against postural assessment. Now, maybe you've signed up because you want to learn about postural assessment. You think it's useful and valuable, as I think it is. But there are quite a few people who don't believe you even need to do it. And I'll talk about that as we go through. But I'm not going to go into the arguments for and against that, and there are quite a lot of them. If you're writing a research paper or a journal article, then obviously it'd be useful to know that background information, but I'm trying to focus on the practical elements today. And what I'm going to focus on is the traditional method. Now, what I mean by that is the kind of assessment that most physiotherapists, osteopaths, chiropractors, sports therapists, what they may be doing. I know some yoga instructors do postural assessment rather than some of the newer forms of assessment, or some of the assessments have been around not quite so long. So this is, if someone goes for a physio or chiro, for example, or an osteopathic assessment, what might those people be doing? Even sports massage therapists, they sometimes do postural assessment as well. What I'm going to teach you today, what I'm going to share with you, that's the sort of experience they may have had with those other clinicians. I think it's a lot of fun to do postural assessment. I've done it for many, many years. The photos I'm going to show you in today's presentation, these are all people who volunteered. So they're people I've known in the past. They've been therapists and people that I've met, and they've all volunteered to have their photos taken and to be shared with other people. So that's where those photographs come from. So, oops, I don't know what's up with my cursor today, it's playing up. One thing I just want to alert you to, and you might not have known about this, but there's not very much evidence for a relationship between posture and pain. And I just want to put that out there, and it's important for us to remember, because it doesn't mean that if someone has a posture which is asymmetrical, so they're not symmetrical, that's why they've got neck pain or shoulder pain or back pain. It might have nothing to do with their posture. There's an awful lot of research into posture and pain, and there are lots of challenges as to why we can't seem to find a relationship. And again, I've got a lot of information about that, and one of the reasons is that the researchers all use different methods of assessing the posture, the different methods of measuring posture. So that's one of the problems. But you just need to bear that in mind. It doesn't mean that if you identify that someone has scoliosis, for example, that's why they've got back pain. And in fact, there is no relation. There's no evidence for a relationship between, say, scoliosis and back pain. So I just want you to be aware of that before we start. But here are 3 questions and some answers before we get cracking with the nuts and bolts of how you actually do it. Why do a postural assessment? I'm going to just expand on that and give you some background information in case anyone asks you, any of your clients, well, why are you doing that? What was the point of it? Why should I have a postural assessment done? Who should have a postural assessment? Should you do it on everyone? Are there any people that you shouldn't do it on? And when should you carry it out? At the start of the the consultation, the very first time you meet someone, or later down the line when you've got to know them. So the first question, why do you do a postural assessment? Well, there are 3 main reasons. The first one is to get more information. So you probably know if you go to the doctor or you go to see a specialist, they ask you lots and lots of questions. And in fact, the history taking, I would argue, is the most important part of your assessment of a client. You're trying to find out not only what might be contributing or even causing their symptoms, but what might be some barriers to them recovering from what the problem is. So they might have pain, or they might have dysfunction, or they might have both. So you're also trying to identify barriers. How long have they had the problem? How long might it take to go away? And the assessment, the postural assessment, is one of your elements of what might be multiple assessments. So it's to give you more information. And a good example would be, often I assess manual workers, and they've come in and they've got a hip injury or something, or a hip problem, and you assess them and you notice there's a scar on their back, and they say, oh yes, I forgot to tell you, I had my a kidney taken out 2 years ago. And then you might notice some scars on their knee or something. Oh yes, no, that's when so and so dropped a trolley on the back of my leg, and I had to have surgery. And all these things come to light. So it gives you a lot more information. For example, I had someone who had come with something completely unrelated to their foot, but when I looked at their foot, the ankle was in a bit of a strange shape. They'd fractured their ankle when they were a child at the age of 6, and they'd not been able to walk on it for months. I mean, something like 4 or 5 months. It was a very serious injury. And so during a period of time when they developed, their skeletal system was developing, they were not bearing weight on that ankle. So as a consequence, they'd actually always borne weight on the other side of their body. So you can imagine the effect that might have had. So they were quite asymmetrical, and they were quite worried, even now as a very mature adult in their 50s, to place weight on that side of their body, even though it was fully healed. Because of this, childhood injury. So that gives you information that you might not otherwise have had just from taking a history. So that sort of leads on to the second thing, which is that it can save you time. So getting that information up front can save you time later down the line. And of course, to establish a baseline. Now, what do I mean by that? Now, let's say someone is interested in having their posture assessed because they want to correct their posture, or they think they've got poor posture, or someone's commented on their posture, and it's important to them. They think that they're getting a dowager's hump. That hump on the back of the neck you sometimes see, it's called a dowager's hump. And they think, oh no, their posture's getting bad, and they don't want to end up like their mum or their father or someone that they know in their family, or their sister or something like that, their older sister. If you're going to give them postural correction exercises to do, and you're going to stretch out some of their muscles and try and impact on their posture, well, you need to have a baseline, don't you? You need to know what it was to start with. And that's relevant to any part of the body. And just the way that if someone was having a knee replacement surgery and they've got a very bent, a misshapen or deformed knee, the surgeon might take photographs, they'll take measurements, they'll take x-rays. So they need a baseline before and after their intervention. Of course, their intervention is surgical, but our interventions as therapists, I'm guessing most of you here, you're not going to be surgeons in the group, but you're therapists of one kind or another. So you're a massage therapist, so you might be an exercise or fitness professional, you might do yoga or something like that. So we need to still establish a baseline, and that's very important. So who should have it? Well, it's useful for most people. It's very rare that I meet anyone that it wouldn't be useful for, but of course I do sometimes meet people who actually decline to have it. And they might decline on cultural reasons. They don't want to expose certain parts of their body, and of course we have to respect that. And it limits the information we can gain. We can't make people reveal parts of their body to us that they don't want to reveal. And you have to just, be sensitive about how you discuss that with them. And it's obviously that you get more information if you can see that part of the body. And of course, it might be for an emotional reason. It might not be cultural. They might just not want you to look at that part of their body. They might be embarrassed about it. And of course, people have concerns about their body shape and size, don't they? Some people are concerned about cellulite. Some people might feel that they're underweight, that kind of thing. And this all plays into how they hold their bodies and the postures that they hold themselves in, doesn't it? And that's a whole different discussion we could have about how we actually get people to reveal their bodies in the first place. So just really quickly, a couple of times when it might not be appropriate. So if a client was very anxious, if someone's very nervous, you know, ask them to stand in their underwear in front of you while you look them up and down. That's not going to make them, you know, you're not going to gain rapport with someone like that, are you? So, you know, it may be later down the line, it might be useful, but I wouldn't, you know, worry too much about trying to get that sort of person to reveal themselves in their underwear to you. If someone can't stand, you know, because they've got pain, and today I'm going to show some pictures of people standing to have their posture assessed, then again, that's not appropriate because it is unsafe. And in the yellow box, I've written down that if someone couldn't stand, for example, due to balance issues, they haven't got any pain, but they're quite unbalanced. So again, you've got to be quite careful, because when you're learning postural assessment, it takes you quite a while to do that. And so you might have your family or your friends standing for quite a long period of time. And in fact, I did have someone, very able-bodied, I was teaching a class a few years ago, and we had a group of people, and then there was about 20 of them, and 10 of them had been assessed and the others were doing the assessment, and we were only 10 minutes into the assessment as somebody fainted. And of course, so you need to give people some guidelines about the fact if they feel lightheaded, then do please sit down, obviously things like that, especially when you're first learning to do the assessment. And of course, if a client doesn't understand the purpose of the assessment, you know, they're in their underwear standing there, and if they don't understand why that you're doing that, then that's not appropriate, because they need to understand it. And it might be that they have a cognitive issue, that they can't understand it, for, you know, they're cognitively impaired, because you have to get consent for any of your assessments or treatments. So you need that person to say, yes, that's fine, I'm going to stand in my underwear, and you're going to look me up and down, you're going to make some notes, and you're going to form an opinion as to what might be going on as a result of that. So you do need to get their consent for this. So when should we do it? At the initial assessment, well, I did used to work for a company, and it was mandatory. We had to do it on every single assessment, and that's because the head physio at that time believed it was absolutely crucial to do the assessments. They were really important. And of course, if that person didn't consent, that was absolutely fine, but you couldn't omit to do it if they had consented to do it. You couldn't be the clinician that had failed to do the assessment, because they felt this head physio felt it was so important. I tend to do it almost always, because almost always you get extra information, but again, there are some reasons, times when I wouldn't be able to do it. Again, following intervention, I'd always do it following intervention. So if I've done an initial assessment and I think some intervention I'm going to do is going to be beneficial and correct posture in some way, or something I'm going to observe, then I would always do it afterwards. And I'll give you an example. If someone comes and in the assessment you notice they've got a very swollen knee, and they've had a knee injury or something, and you do some massage and some manual lymphatic drainage or some effleurage or something lovely to reduce the swelling. I might have measured the girth of the knee to start with, like, you know, the diameter, the circumference of the knee rather, and I might measure that afterwards, but I might also do an observation. So I observe the knee before and after, and it might be that you can't, you know, your observation isn't enough to tell if the swelling's gone down or been reduced. It might be that you do need to measure it, but that's an example of when you might have done just a massage intervention. If you've been doing some stretching, you're trying to correct, for example, a kyphotic posture, you're trying to stretch someone out the other way, you don't want to be so round backed, and you've given them exercise to do at home, you're not necessarily going to do it on the next appointment that you see them, because they might not have done enough to make a change. You know, how long does it take to change posture? And we don't know is the answer, because there's not been enough studies with the same groups of people with the same body types to be able to answer that question. And it might be that you're going to give them this and they're going to work on it for 8 weeks, and then you're going to come back and has their posture changed, you know, that kind of thing. But of course, you could do it as a standalone assessment, and I've actually done an awful lot of these, and I'll tell you how that came about. I worked for a company, it was a corporate gymnasium, and I worked in the gymnasium. I was a fitness instructor for many years before I was a massage therapist and before I was a physio. They wanted to get more people to use the gym, because they recognised that there was a lot of absenteeism from back pain and all sorts of problems. And this was a company though everyone was seated at desks, and there was a lot of high-level management there, and they were very stressed out, and they wanted to get them to come into the gym and use it for stress management, all sorts of things. But one thing I got asked a lot when I was going around and doing DSE assessments at people's desks, which was another service that was provided, I got asked a lot about people's postures. So I said, well, why don't we do postural assessment as a bespoke assessment? So these people would then come to the gym and have their assessment their posture assessed, and that's because we had to do it in the gymnasium, to physically get them into the gymnasium. Well, if you want your posture assessed, you've got to see Jane Johnson, the fitness instructor. She's actually down in the gymnasium, so you have to find the gymnasium. That's like, you know, the first goal of getting people to a gym, isn't it? It's actually to find it, get through the door. And then, of course, we actually went into a private room, and they could have their posture assessed. And so what we did was, that was it took at least 20 minutes, usually, you know, more than that. And they had a very detailed report that was provided about their posture. It didn't tell them what to do about it. It just said, these are our observations. And then, of course, they'd come back and they'd have a consultation, and we'd say, well, actually, if you strengthen this muscle up, and we can help you with that, and we can use this piece of equipment, or you could use these free weights or these TheraBands. So that was a really useful way of getting people to do some physical activity, but they were very interested in it. And I'd say that most of the people who had their posture assessed then began to use the gym in some capacity, even if it was just to lie on the floor on the mats and do some stretching. You know, it was really valuable. So what equipment do you need? Well, you need a warm private room. If you're doing the DSC assessment, now some of you attended my webinar last month on display screen equipment. You tend to do it much more quickly then, and you're at someone's desk, you're at their workstation, so that's slightly different. But if it's any other time, then, you know, in a warm private room, that's preferable. It might be your treatment room, your gym, an area in your gym, something like that. A full-length mirror, that's optional. That's useful because they can see what you're doing when you're standing behind them. Body cranes are optional, but they're really handy, because when you've got body cranes, you can draw on people with their permission, and you can take photographs and all sorts of things, and especially when you're learning. So we're talking about the sort of face crayons that children use, you know, at parties, get their faces painted. In the UK, they cost about, I know, 25 pence for a packet, up to £1.50 for a packet. But a tip I would say is, do get some which are light coloured. So you've got some which are pale, you know, white or yellow, as well as some of the darker, vibrant colours, because of course we've all got different skin tones. And if you're working on someone with a darker skin tone, then you know, a navy blue body crane is not going to necessarily show up so well for you. Interesting about the navy blue, they don't always come off very well, so that's a little tip. A model skeleton, that's optional, because if you do go on to decide about postural correction and you want to attend any of my webinars on postural correction, there's lots of those. They're very straightforward, step by step, how you actually do it for different parts of the body. Then having a skeleton is very useful to teach your client about the postures and the underlying structure that their body might be in. And of course a chart. Now the one on the left, that's just one part of a much longer chart. That happens to be from my book. There's a little picture of it there. So if you've got my book, that one at the bottom, the postural assessment book, it's at the back. That chart's right at the back. I wrote that book years and years ago. It's 10 years old now, a step-by-step assessment, because I couldn't find any detailed how do you do postural assessment books. There's a very useful book by Kendall and McCreary. That's a very old book, very valuable, but it's also got lots of other information in it about muscle length testing and function. And for some people, that's just too much information. So if you want just postural assessment, I couldn't find anything with the charts in that was a step-by-step guide. So that's why I made one. I have actually asked my publishers repeatedly, could we publish just the assessment chart? But for obvious reasons, they want people to buy the book, so then you can actually know what to do with that chart. But, you know, I have actually asked them quite a few times about that. And obviously I can't provide it because I was under contract for that publisher to write that book. But anyway, today you won't need that chart, because I'm going to give you enough information. The images I'm going to share with you that are from that book, you'll have enough information. So how much time should the assessment take? Well, this first one might surprise you. During a DSC assessment, so a display screen equipment assessment, if you're assessing someone at their workstation, if it's, you know, face to face and you're actually there with them, we're looking at 60 seconds. You know, how are they sitting at their desk, using their equipment, front, back and side? What are they doing? So usually you can't get in front of them because they've got a display screen in front of them. So you'll do it from both sides and you'll do it from the back. And if you can't do that, just from one side and the back. Is the equipment in front of them and all that kind of thing. So if you want more information about that, have a look at the display screen equipment webinar. Have a think about signing up for that. But it really is something very quick, because in those assessments, you've got a lot of other things you need to be looking at. But normally in initial consultation, that might be 2 to 5 minutes. Now, if you're listening to this as a massage therapist, you might be thinking, 2 to 5 minutes, Jane, what are you talking about? We've got a whole hour with someone. But what you've got to bear in mind is that if you're going to provide massage service or, you know, another therapy that takes an hour, how much of your hour's time do you want to cut into doing an assessment? Are you going to provide it as a separate treatment? And if so, who's going to pay you for that? And maybe it's going to be provided free, but then, you know, that cuts into a bit more of your treatment time, you know, that kind of thing. As a physio, our appointment times are typically 30 minutes. So our assessment and treatments are 30 minutes. So of that, we also have to write a lot of clinical notes, and we have to do a lot of other assessments. So you get very good at doing this very quickly. So it really does take about 2 to 5 minutes. And obviously, when you're learning and you're a beginner, of course, you're not going to do it in 2 to 5 minutes, but you want to be thinking about what are the key things I'm looking for. If you spent an hour looking for stuff, of course, you could find all sorts of things, and they might have no bearing at all on that client. So one of the best tips I ever got when I was a junior physio was to do things and just look at the obvious things, you know, try and think what really jumps out at you. And you might be thinking, Jane, nothing's jumping out at me. But I promise you, the more you do, the better you get at it. It's like anything. So if you were doing a specialised report, you might be looking at a minimum of 20 minutes. I mean, if you're charging someone £100 for a report on their posture, you really want to do this. And there are lots of different ways you can do it. You might be taking photographs. You might be providing them with photographs. You might be doing it against a grid. You know, there are lots of different ways, you know, you could do a postural assessment. And to really hone in on it, you could we put arrows on them, we'd highlight the key things, each part of the body would be itemised. Even if there was nothing wrong with it, we'd say there was nothing obvious in the postural assessment, you know, related to knee flexion or, you know, knee posture, that sort of thing. Or we might say the position that your postural assessment from the side indicated that your right shoulder is protracted. Protraction means, you know, bloody, bloody, blah. And we tell them what that meant, that kind of thing. So how are you going to document all of this? So if you're going to do it quickly, how are you going to do it? Here are just 4 ideas. Well, we've mentioned you could use a body chart. You could scribble on your body chart. And if I scroll back to it really quickly and I just show you, the way I used to do it, this is how I learned when I was first doing it, was I drew some pictures out in the middle of the chart, and what I saw on the left of the body, I drew on the left, and what I saw on the right of the body, I wrote down on the right side of the screen. The right side of the chart. So I knew what was on the left and I knew what was on the right. I might do some shading. If someone had more tone on one part of the body, I just did some scribbles because I knew that a scribble meant shading. If they had a sharp stabby pain somewhere, I'd put a little cross because I knew that my cross meant sharp stabby pain, or I did it in a red pen, you know, something like that. If they had a shooting pain going down the side of the neck, I drew a little red line because I knew red lines meant shooting pain, that sort of thing. And there's no right and wrong way of doing this. There are lots of different ways that you could do it. It was what works for you. So the second thing is to write longhand notes. Now, a lot of people don't use charts actually, and they just write out their observations in longhand. I find charts helpful because I'm very visual, but I'm also what's called mathematical logical. So I have to have things boxed, and, you know, I like to group things and I find connections that way. That's how I learn. But some people don't. They really like to write things out. Other people like to listen to the audio tapes, and they're very auditory, but there is a downside to auditory recording, and that's that your client can hear what you're saying. Now, you have to be very careful about that, because obviously if they're listening to what you're saying, you know, they might want to ask you about it, and you might not want to share everything with them, and you certainly might not want to share it with them while you're doing the assessment. You just want to do the observation. So you have to be a bit careful about that. And of course, you could, with permission, take photographs, just get them to sign a consent form. Obviously, these are confidentially, got to be careful how you store them, obviously. And you have to have that consent. And then, of course, you can share them. And photographs are incredibly useful. We're doing the traditional method today. There are apps you can get on the market that take photographs of people, and you have to be very, very careful when you're using those apps that no one else can access that electronic data, including the app technicians who troubleshoot problems with that app, because that is against GDPR. And if you're sharing that information, or you're sending that information to somewhere, you have to make absolutely sure that you are compliant with GDPR if you're, certainly if you're in the UK, because that's confidential data, that's confidential information about that person. So you must be very careful about that. And also, I spent a long time in my PhD looking at apps and whether they're valid and reliable, and are they actually measuring what they are supposed to measure. So again, there are you know, 1 or 2 good ones out there, and there's other things other than apps, but you just got to be very careful about that. So one tip, think about how you might feel having your own posture assessed when you're doing a postural assessment, because when we do this face-to-face, and the FHT run postural assessment workshops with me, and some of you listening might have attended those workshops, but they're very popular and run them, until we were in a pandemic, we were running them all the time. Some people don't want to have their posture assessed, and that's absolutely fine. It's really valuable, because having someone stand behind you or to your side or your front while you're in your underwear, you suddenly realise how exposed you feel. And obviously you don't normally do that in front of lots of other people, but it can feel very exposing, and that's one of the reasons we do the assessment quite quickly. So today what I'm going to teach you is back, side and front. And we're going to spend the rest of this webinar talking about the back, side and front views, and all sorts of things you might find. Now, I can't get everything in, but I've got as much in as I possibly can. There's a lot more information in the book, obviously, but I'm going to give you as much as I can. So there's going to be enough for you to go away and do some really good and valuable postural assessments. Why do we start with a back view? Well, my answer is because it might be less intimidating for the client. If you're, standing in front of someone and they're in their underwear, they might feel a bit intimidated. And if you're standing behind them, you could argue it's a bit less intimidating. It actually doesn't matter where you start, and it doesn't matter what order you do everything in. But what I would recommend is that you are systematic. And when you're learning, I'd recommend that you do try every part of the body. You don't have to try it all at once, but because everything's connected, you start to see connections, and you start to see when things don't look right. So let's draw back the curtains and start. I'm going to be drinking a cup of my tea because I've been talking a lot. So, head and neck position. One of the things you can have a look at are the head and neck position. So what are we going to look at? Well, think about, is the head and neck laterally tilted? What do we mean by that? We mean, is the head tilted to one side? Is the ear closer to the shoulder on one side than the other? And one way to do this is to look at the tips of the ears and ask yourself, are they level? So if you look at this lady, do you think the tips of her ears, her earlobes, are they level? Is the left ear level with the right ear? If I show you this arrow, this line, you can see that they're not symmetrical, they're asymmetrical. But you have to be careful about this, because you can have one ear that's larger than the other, and you can have one ear positioned lower on your head than on one side than the other. If you then look at the neck actually, you can't quite see it because of her hair, and I'm going to come on to that in a minute, but the neck doesn't look that it's tilted to one side. The neck looks fairly straight. And with postural assessment, you build up an image of what's going on, and you'll combine this with other tests that you might do later on that are not to do with observation. They're not assessment. They're other types of tests, like movement tests, that we're not covering today, to work out whether there is lateral flexion or not, for example. So in this example, it appears that one is lower than the other, but the neck actually appears symmetrical. It doesn't appear more flexed on one side than the other. What do you do if you can't see all of the back of the neck? Because you want to have a look at the back of the neck itself. Should the client hold up their hair? What do you think? Some of you are probably shaking your heads and saying no. No, because you know yourself, if you were to try and hold up the back of your hair, if you've got longer hair, it's going to immediately change the position of your shoulder, and it's going to change the position of your neck. So lateral flexion is caused by all sorts of things, but the muscles that might be short and tight in lateral flexion are the levator scapulae and the upper trapezius on the side to which the head is flexed. So if you take your left ear to your left shoulder, you've contracted your levator scapulae and your upper trapezius muscles on the left side of your neck, and that's what's brought those muscles over on that side. There's a few other things involved, but those are the basics. Another thing to see is about rotation, and I get quite a lot of stick about this, but it's really interesting, because if you look at this gentleman here, and these photos were taken very carefully. The photographer who did this was very, very careful. We had a studio set up when she took these photos for me for the book, and it was very, very careful to get the lighting so there were no shadows, and she was directly behind the person or directly to their side, and I explained why that was important. And this gentleman has a slight rotation of his head to the left. And you can see that because you can see a little bit more of his jaw on the left than the right. And you might be thinking, hey, what's that got to do with anything? Well, if someone's working at a workstation and they're not got everything in front of them and their head is slightly turned to the left because they use a monitor or one of two monitors more than the other, then this is what you tend to notice. They tend to, over the months and years, they start to develop a tightness in the muscles or a rotation in the head to the left. And what you do about that is a little bit more tricky. And that's why I can't get postural correction in this webinar, because some of the muscles that rotate your head to the left are not on the left side of your body. For example, sternocleidomastoid is a muscle on the right side of your neck, but it turns your head to the left. So that's a little bit tricky. But some of the muscles deep inside the cervical spine, on the left of the cervical spine, they are maybe shorter and tighter. And that's why those of you that do hands-on therapy like massage, you will know that when you're palpating the neck, when you're poking about in there, the soft tissues, you might feel that actually when you assess this person, the muscles on the left side of their neck, their deep cervical muscles, they are tighter on that side. You can feel them. There's a tonicity, an increase in tone. Think about the shoulders. Are the shoulders level? Now, if you look at this gentleman here, his shoulders might appear to be not quite balanced, and some of you might be saying, well, I can't quite see that, Jane. Can you make that a little bit more clear for me? Have a look here. See, I've tried to draw. I used an electronic drawing tool to draw over here, but this is a really good thing you can do with photographs. You can draw over a photograph. It could be the photograph of that particular client, or when you're practicing over photographs of yourself, that kind of thing. And have a look at the height of the shoulders and also the position of the neck. And can you see the arrow that I've drawn there? That's kind of where the neck joins the shoulder. And you can see that it's slightly sharper on one side than the other. So you can maybe trace the line of your client's shoulders with your eyes if they're standing in front of you, or maybe physically trace over an image. Have a look at this. Now, if you're looking at this on a mobile device, like a phone, you might not be able to see it very clearly. I didn't want to obscure the photograph, but maybe I should have made these a bit darker. There are two vertical lines here, and I've drawn the vertical lines where the neck joins the trapezius muscle, the crease here. And if you look at the left, there's a bit of a gap, but there isn't a gap on the right. And that's because the head is slightly flexed to the right. And if you draw, can you see this here? If I draw a line on it, if I go back up again here, you can see the head looks like it's shifted to the right. But if you look at the ears, there may actually be a little bit of tilt here. Now, there's quite interesting what might be going on here. It might be that the neck is not entirely flexed. So in other words, he's not taking his right ear to his right shoulder. What might be happening is that the upper cervical vertebrae are slightly tilted, because obviously your vertebrae move independently of one another as well as a group. And it might be that there's tension in the upper part rather than flexion of the lower part. So again, that's where you have to use palpation and use some out, well, does it feel tight up there? And of course it might have nothing to do with anything he's come to you with. If he came with headaches, or neck pain, I definitely want to look at that, but it might have nothing to do with that. So you do need to be very careful about jumping to conclusions. Just because someone has this posture doesn't mean that's the cause of their problems. And I really want you to take that away as one of the take-home messages from today's webinar, because at the moment, we just don't have enough research to show a relationship between posture and pain. Another thing to look at is the length of the neck. Now, I'm not saying that one of these necks is better or worse than the other. It's just that it is something to observe, and it could have some bearing on that person's condition that they come to you with. Because again, when you look at the front of the body, people have goiters, don't they? They have issues that are going on the front of the neck, and you would need to observe that. And I had a lady who came for an assessment once, and she actually had a scarf wrapped up around her neck. And it was, it wasn't a particularly warm day, and I didn't think anything of that. And she kept it quite up high up near her ears. And it wasn't until I asked if we could do an assessment that she revealed she had a very, very large goiter swelling on the front of her neck. And so she always wore that scarf because she was embarrassed about the way that looked. So again, it's about getting more information. It gives you more information. And you ask yourself, does it look squashed up? Does it look lean? Does it look fatty? What might be going on there? Again, sorry, if I just jump back to this one, and I don't know if you can see my cursor on the screen here, but It's not apparent in either of these photos, but sometimes the cervicothoracic junction, so in other words, where the neck joins the thorax, it's the C7 and T1 vertebrae, those junctions, you get a build-up of fatty tissue, and it is just a fatty tissue. There is a hormonal component to it, probably, because it's more common in women than men. And can you get rid of it? Well, that's very interesting. Now, I would never have previously said you could get rid of that, but actually I've worked with people and it has gone away with massage and posture correction. And it's possible that, you know, when we tension that particular part of our body, that deposit of fatty tissue is as a response to the abnormal strains and stresses when you have a forward head posture, combined, for example, with certain hormonal influences, because, you know, why would it be more common in women than men, for example? You can't say that more women have a forward head posture than men, because we don't actually know that. So again, think about the shoulder blade, the scapula. What position is the shoulder blade with respect to the spine? So again, I've highlighted where use of body cranes is useful. I put a big yellow highlight over it. If you think about the medial border, so that's the border of the scapula, the shoulder blade, that's closest to the spine. So while you're sitting and you're listening to this, I've been talking for half an hour now, so let's just move your bodies around. Protract your shoulder blades around your rib cage and they'll move away from your spine. So that's protraction, and then squeeze your shoulder blades back, contract your rhomboid muscles. That's the medial border moving back towards the spine. And this is very important when I've found when people have a shoulder problem. So if they have impingement problems at the shoulder, quite often when you've got impingement on the front of the shoulder, I have to teach them scapular retraction exercises and scapular setting exercises, and these are all sorts of things we cover in the posture correction webinars, because it definitely makes a difference, the position of the scapula, irrespective of what any research articles may have found. I have found in people like swimmers, people that are desk-based, people who predominantly use one side of the body compared to the other, when they get shoulder impingement syndromes, if you can, almost always they have a protraction of one side of the body compared to the other. And that is apparent when you do their postural assessment. And so if we can teach them that and educate them about the position of the shoulder blades, that's crucial in helping them to self-manage that condition. Again, look at the muscle bulk and the tone. Think about what that might mean. So hypertrophy, that means when there's a lot of muscle, means repeated use of that muscle. Hypotrophy, when there's less, there's wasting away, that's disuse. So if someone had a frozen shoulder, you would expect to see disuse, and that's because they physically cannot move that shoulder. So a muscle called infraspinatus, which is in the middle of the scapula on the back of the shoulder blade, that would waste away. Now this gentleman's got normal, he's obviously does some physical work, whether it's part of his job or strength training, because he's got quite a lot of muscle tone here, muscle bulk here. He doesn't have disuse, but if someone had a frozen shoulder on the left, you definitely see that wasting compared to the right hand side. It's very apparent, and the longer that condition goes on, the more wasting there is, because they physically can't move that shoulder and they lose external rotation. So the muscle, a prime muscle, infraspinatus, that externally rotates, that's going to waste away. And that's a key thing that you'll observe. So let's have another look at something else. Tracing the shoulder height. Again, if you think about this gentleman and you would trace your eyes along his shoulders, along the outside of the shoulders, would one shoulder appear higher than the other? You could ask yourself, what do you think about that? Think about here and here. Look at the difference between the point on the left where the neck joins the shoulder and the point on the right where the neck joins the shoulder. Is that shoulder higher, or is there more bulk on that side? And again, we don't always know, and that's why you might have to do strength testing, you might do range of movement testing, or you might just get in there with your palpation and just feel, is one side more toned than the other, has one side more painful than the other, and it might make no difference at all to his condition. It might have nothing to do with his neck or shoulder pain again. But it's a lot of fun, I find, to see, because in my experience, I have often found correlations between the posture and the symptoms people are describing. Think about overall spine shape, and here's a tip: stand quite far away from your client. If you stand too far, you don't get the impression of what's going on. This is the gentleman that you saw straight earlier. First of all, when we talked about the neck posture, I drew the lines over his neck. This is the same person. Look at the shape of his spine. He has an asymmetrical spine. Now, most people do not have straight spines. And obviously, you've got one of my, the challenges I come across so much is when people have been told by a clinician, oh, you've got a scoliotic spine. Honestly, you've got to be really careful when you say that to people, because you don't know what effect it's going to have on them. And unless you actually know they've got a scoliotic spine, then I would avoid saying that, because what are you going to do when they say to you, well, what do I do about that? By how much is it scoliotic? You have to be really careful. And it might have nothing. There is no evidence that having a scoliotic spine gives you back pain, as I mentioned before. So you've just got to be really careful. And some people can become incredibly paranoid about then revealing parts of their body, even to their partners. If you say something like that to them, and often they've been told that they've got a scoliotic spine by another clinician, and they think that is why they've got neck pain, and it might have nothing to do with that. So you've just got to be careful, and we've got to help re-educate other clinicians about that as well. But this may explain why this gentleman, his neck is in this position, because our bodies try to always right themselves. So they might, they're out on the right, sort of over the left here, it's curving that way, then it's curving in over here. So the body tries to right itself. And you can see that because if you actually, we're not going to cover this today, but if you look at his arm position, our shoulders are quite complicated. And that's why we've got a whole separate webinar about postural correction of the shoulder, because there's a big gap here on that side. Now, that could be because of what he's doing with his arm, in terms of his job, but it could actually because of his scoliotic posture has caused him to have to deviate his posture to the side there. Think about the height of the pelvis. So there are two ways you could check this, and everyone laughs at me, but I promise you, I found this time and time again. Look at the underwear. Look at this lady's underwear. It's going up on the right. If you look at the buttock creases, this is just a buttock crease. It's a fat crease. It's not actually necessarily telling you about the underlying gluteal muscle, but it's higher on the right as well. So this pelvis is raised on the right hand side. Her knee creases are equal, so the back of the knees are kind of equal. So it's possible that she's got a longer femur on that side, and that's pushing up her pelvis on that side. Or she's trying to just hip hitch on that side, but it's quite possible that bone there is longer, and so she's been born, she's got a longer bone, and that's normal. I see that in the dissection lab all the time. Those of you that come in the dissection lab with me down in London in King's, we see this a lot. Bones are not the same in everyone on both sides of the body, but not symmetrical. If you think about the shoulder as well, you can see that what shoulder's higher. Look at this right shoulder. Would you agree that she sort of looks like she's dropped on that side with the shoulder and raised on the pelvis there? So she might have a shorter muscles sort of in here. So quadratus lumborum, the erector spinae on the right side of the back here, they may be shorter and tighter on that side. And again, that's when you would test her. So you do muscle length tests to work out if she's shorter on that side. What you can do to check pelvic height, again, is you could put your hands on their pelvis. So what you do is you squeeze them in at the waist, right up on their waist with your hands. You stand behind them, you squeeze in at the waist, and you push your hands down so you can feel the iliac crest. So you do it on yourself. If you put your hands on your waist while you're listening, squeeze yourself in and then push your hands down. You can feel your pelvis at the back, can't you? You can feel the bony ridge of your pelvis. And what you're trying to feel is the uppermost part of that ridge, the highest part of that ridge. It's easier to feel at the sides of the body, the waist, but it's actually quite ticklish for people, so that can be a bit tricky. Look at this lady. Which side of the pelvis is higher on her? Where do you think her pelvis is higher, on the left or the right? Again, if you look at the line of her underwear, her left side is slightly higher than on the right side. And that's because the underwear, but again, if you put your hands on her waist, you would be able to tell that. Think about the overall stance. Now, again, this is something very interesting. I wasn't sure about putting this in. I kept taking this slide out and then putting it back in again. If you think about overall stance, and this is where you get very good at this if you do a lot of them. If you look at the lady on the right, she's actually standing quite upright and she's drawing her shoulder blades back. How do I know that when I can't even see all of her upper spine? Well, I can see a bit of her left shoulder blade, her scapula, a little bit. Her right shoulder blade, I can see a little bit of tone that looks like a little dimple. But the key thing is, look at her elbows. Where are her arms in relation to her waist? would you agree that she's drawn her shoulder blades back and drawn her arms back more than the lady on the left? Now, I know for a fact the lady on the right is a yoga teacher, and she has hypermobility, and I know she doesn't mind me sharing this with people. I've had her permission to do that in the past. And so she has to correct her posture because she gets a lot of low back pain. And so she's got this she's got a lot of laxity in her joints because she was born like that. So one of the ways she's learned to stand upright rather than slouching, but as a consequence, she draws her shoulder blades back and her elbows are drawn backwards like that. And also you look at her hands, you can see where her hands are in relation to her thighs. But if you look at the lady on the left, you can't see her hands. They're slightly more in front of her thighs. And that's a hint sometimes when people have a forward shoulder posture, a protracted shoulder, you can't see their hands. And again, we go into this in a lot more detail in the shoulder correction webinar. And this is why I say I can't get it all in at one, because you can see that she's actually imbalanced as well, because her left hand is not the same as the right. And you can practice this yourself. If you stand upright and you form a kyphotic posture, you protract your shoulders, look at what happens to your hands. One of them will come in, or both of them will come in front of your thighs. The other thing to look at, I'm sorry this blue arrow's come out a bit pale, is the PSIS, the posterior superior iliac spine. These are the little dimples on the back of the pelvis, and some people you can't, if you can't see them, don't worry about it. But it's quite useful if you put a little crayon mark on them, and then you can show people. And you know, they might have their pelvises might be slightly higher on one side than the other. On this photo, it's a little bit difficult to see, and I've slightly obscured it with the arrow, but in fact, the pelvis is slightly higher on this side. And the reason the pelvis is slightly higher, the dimple's higher, is because this gentleman also has a slightly curved spine. It's not entirely straight, and it's perfectly normal. Lots of people, you know, we're not symmetrical, and that's nothing to worry about. Again, if you look at this gentleman's elbows, if you look at the elbow on the right-hand side, look at the position of the elbow on the right side to the elbow on the left. So what has he had to do to the elbow on the left-hand side to get it to look like that? His left shoulder is internally rotated. His right shoulder is more externally rotated, relatively speaking. And you can practice this. You can put little marks on your elbows, and you can turn your hands one way and then the other when you're standing up, and you can see what happens. And again, have to think about how they stand. Now, I've been talking for 40 minutes. You might want to stand up while I'm talking to you, and have a little look how it feels like. If you stand up and you stand with a wide stance, if you're someone who naturally stands with a wide stance, that's fine. And if you're that sort of person, and then I ask you to stand with your feet close together like this, notice how you feel. Now, some people will always stand with a wide stance because relative to other muscles, their adductors, so their adductors of their hip that bring the legs together, are weaker than the abductors of the hip, so the muscles that take the hip out, relative to the abductors. Now, that doesn't mean the adductors, the ones that brings the legs in, are weak and completely weak. It just means relative to their own abductor muscles, the ones that take the legs out. So they might have strong muscles that bring the legs in, but they're just not as strong as the ones that abduct, that take their legs out, their buttock muscles. And you can tell that because if you normally stand with your legs far apart and then you stand in a narrow stance, you won't like that because you'll feel unbalanced, and you can feel your adductor muscles trying to keep you together, trying to keep your legs together. I've got some text has appeared on my screen. I don't know where that's come from.
I've just seen that. I'll try and get rid of it.
Yeah, don't worry about that. It's actually come up in.
It's gone.
You know what it was? I think it might have been Italian or something like that. So some voice activated software's come on. Yeah, so that's quite interesting, and that could lead on to other discussions with that person. So, for example, if you're watching this as a fitness instructor or a yoga teacher or someone that does, helps people, a coach with strength training and stuff, you might want to discuss with your client about a balance work, balancing the abductors with the adductors of the hip, for example, and because you might feel that that's going to be important later down the line. Again, always think about swelling in the knees. And again, we're looking at the back view, but we would look at everything from all viewpoints if you can, if that's appropriate with your clients. Now, if you've got a piece of paper, think about the genu varum and the genu valgus postures. What on earth are they when they're at home? Well, the genu varum means there's air in them. That's the bow-legged stance. So if someone was bow-legged, if you drew an orange and you try to draw someone's legs on the outside of an orange like a giant. Does anyone remember space hoppers when we used to jump about, bump about on a space hopper when I was a girl? They were really exciting, sort of bright orange things. That makes your legs go in a genu varum posture. Genu valgus is knock-kneed. It's a posh word for the knock-knee posture. Very common in, these are very, very common in osteoarthritis of the knee. And in fact, I have got a webinar. I was talking to Heidi about this earlier. There is a webinar all about knee pain, what do you do with knee pain? Because when people get osteoarthritis and it's very severe, these are the two most common postures that the knee develops into. So general muscle bulk, have a look at that. Is there any atrophy or any hypertrophy? So is there any wasting of muscle or any overdevelopment of the muscle in the back of the leg or the back of the thigh? In this gentleman, he seems to be, a little bit, he seems to be symmetrical. But again, I find it a lot of fun because if you run your eyes down the outside of the image on the right here, his right leg, and look at the outside of that leg, and then you do it on the left, what you notice is that the bulk of the left calf on the outside of his left calf is actually slightly higher than on the right. It sort of starts to get a bit bulky higher up, or is slightly different. And sometimes you can't even work out what's going on. But sometimes people have a predominance for one leg, and so they'll develop, a calf more, more in one side than the other. And you definitely see this following injury. So someone's been in a cast, or they've been immobilized, they've had surgery. This is definitely something to look at. It might be something that, if we've got a lot of people at the moment with, at the time making the video, with long COVID, I've got a lot of long COVID patients I'm treating who've been very fatigued. They find it very difficult walking about. Their muscles, the whole of their lower limbs will have wasted away, and they're starting to get severe atrophy in the lower limb. It's an extremely serious thing we need to eventually focus on and work on how do we develop these people and help them get better. So just normal life, like climbing stairs. Again, I wasn't sure about putting this in, but I want to give you as much information as possible. Usually, this does require a little bit of support when you're learning about this. If you draw what look like the headlights of a car over your kneecaps, take a picture of your knees and get some, and on the photograph, draw the headlights of a car over your knees as if they were the headlights, and look at where those headlights would point. So, for example, if you turn one leg outwards, that headlight's going to go out to the side, isn't it? If you turn that leg inwards, that headlight's going to go inwards. So that's a really useful way of learning about the knee position. So again, you could draw down the back of the, sorry, on this one, you could draw headlights on the back of the knee, you could draw on the front of the knee. You could also draw a line down the very center of the calf. And again, practice what happens to that line when you turn your toes in or you turn your feet outwards. And now I'm going to show you some side view. Now I know, I'm sorry, I'm talking very quickly because I've got so much, probably going to overrun a little bit, for which I apologise if you've got an appointment coming up. I've got a meeting after this one or something, or a client. But as I say, you will get the recording, so Heidi will be able to share that with you. Does the head balance over the thorax and the rest of the body? One thing I like to do again is and I usually do this just visually. I imagine if I was to draw a line down the centre of the neck, through the very centre, bisecting the neck in half, what sort of position would that go in? Would that be upright, or would it be slightly forward? And if you do a lot of these, you start to get a feel for what most people have. And one of the questions I suppose you could ask me is, what's normal? And I don't know what's normal. Nobody knows what's normal. It's a question of what's normal for that person. Will they ever get to a different posture? We don't know. You're going to have to just excuse me for a minute because I've got some background noise. So I'm just going to shut my door. Sorry. Sorry about that. So if there's any background noise, that'll stop in a moment. Okay, so again, what I also might do is draw a head and a block over the torso. And I have a look. So if you see this lady on the left, her head's sort of balanced over a block, isn't it? The lady here in the middle, would you agree her head is slightly more forward than the block? And again, this gentleman, the same sort of thing, you know, head might be slightly more forward than the block. And you think, well, why would we care about that? Well, if you think about the strain that's going through the neck of the lady in the middle, you could argue that she's going to have more strain. It's less optimal for the soft tissues on the bones and joints of her body to work if the head is not balanced in the middle of the torso. So that's quite useful as well when you're teaching people about posture correction. And keeping these very simple sort of shape ideas. A plumb line is another useful tool. The problem is, it's very challenging getting people to stand in front of a plumb line. If you use it and you're already using it, you know, you're obviously very skilled. So, hey, what are you doing listening to this webinar? Because you don't need this webinar. If you're not using it, what I would say is, I'm not sure it's worth getting a plumb line and hanging it up because they're very challenging to use. It's better to do it with a photograph and draw the plumb line over the photograph. And the reason it's challenging is you can't get the person in the right place. And that's because in the side view, can you see this yellow line running down this gentleman here? In the side view, you do not position the plumb line with respect to the ear and the shoulder. You position the plumb line about 2 centimetres or a centimetre in front of the lateral malleolus. Now, where's that? If you run your hand down to the outside of your ankle, your lateral malleolus is on the outside of your ankle joint. It's that bumpy bit. And that's where you put the plumb line. And on this gentleman, this was actually where that plumb line was positioned. And he's a very good example. Now, he is actually a therapist and he gave permission to have his photo taken for my book all those years ago. And he is very symmetrical, and he does a lot of martial arts and you know, massage and stretching himself, and that's perhaps one of the reasons why, or maybe he was just born symmetrical, we don't know. But you could use a plumb line to help you assess posture as well. Again, do you think is the neck long or short? So we've got a couple of examples on the outside of each of this page, the left and right, and they're shorter necks, and 2 in the middle, and they're longer. And again, it may have no bearing at all on the person's function. It might have no bearing at all on their pain. One thing I have discovered, and I do talk about this in the other webinars, but certainly the neck webinar on postural correction of the neck, is breathing. Neck posture, you know, we've got scalings in there, and they can help with breathing and things. We do need to think about neck posture when we're teaching people sort of breathing techniques. And in my experience, if you have a more upright posture rather than taking your chin towards your chest, it does help with a better breathing mechanics. Look for any obvious hypertonicity, so extra tone in muscles. Look at these people here. None of these have extra tone on the side of their neck. This lady does. That muscle is sternocleidomastoid, and I know that that lady has extra tone here for a very special reason. It's because from being a child, nobody realised that she's actually almost completely deaf in that ear. So she was always craning her head to one side to try and hear people. The head that she was actually craning was the other side because she could hear out of the left ear but not the right. And if you remember, sternocleidomastoid rotates you to the opposite direction. So, you know, it was very interesting seeing her and sort of talking to her about why she might have this hypertonic muscle on that side of her body. Are the shoulders protracted or retracted? So again, are they forward or are they drawn back? And again, I might draw a little line on the back of the body and a spot over the shoulder. And I do this visually. I don't have to physically draw it now because obviously I've done this for years and years, and you'll all get really good at doing this as well. But it's lots of fun when you're practicing, so sort of try this. If you look at the lady on the left, her shoulder is not that far away from the line on the back of her body. The next lady along, number 2, her shoulder's a bit more far away from the back of her body. And you see we've got these various combinations of shoulder position. And again, it's very difficult to say what is right. You know, I'd be cautious about comparing one person to another person because we're all different shapes and sizes. And that's what's wonderful about being a therapist, isn't it? We get to see all these wonderful different bodies. But it's very interesting when you do start to deal with people who've got problems with the shoulder or the upper back, and then you do some work to correct the shoulder and the back position, and then you take pictures of them again, and quite often not only has the posture changed, but their symptoms have changed. They've usually got reduced, so that's very interesting. Can you remember these back shapes? A kyphotic thorax, which is the normal one. That's the round back. And we've all got a normal kyphotic shape in a thorax, but when you become very kyphotic, it becomes very round. A flat back thorax, so that when it's very flat, that's often when a person's lost the normal kyphotic curve, and they get a lot of pain because of this. And again, I talk quite a lot about that on the webinar about thoracic posture correction, because that is a real problem for people who are hypermobile. Flat back in the lumbar, and this is an example. Actually, this lady here, the second lady in from the left, she's got a flatter lumbar curve. And if you look at the lady second from the right with the darker skin, she's got a very increased lumbar curve. She's a very good example of someone who has this one at the bottom in grey. She's lordotic. So again, you could look at these pictures and ask yourself, you could trace them with a biro over a photograph. Are they flat back or are they lordotic? And the lady who's second from the right, we're not covering this today, but she's actually got rotation in her torso as well. And I know that because I can see more of the left side of her back than the right side. We should only be able to see the right side of her body. And this was very carefully taken, this photo, because her pelvis is rotated anti-clockwise. It's rotated sort of to the left, and you can see some of the left side of her pelvis there. So, position of the pelvis, anterior or posterior tilt. Again, if you add a line to this, it becomes a little bit more obvious. The lady on the left is slightly more anteriorly tilted than the lady on the right. And this is to do with the position of the posterior superior iliac spines and the anterior superior iliac spines. And there's been a lot of debate actually about, well, does it matter? Surely most people are anteriorly rotated. Does it matter? And it might not matter at all. If you look at the lady here on the right with a flat back, she's got a less anteriorly tilted pelvis. And if you look at the arrow showing her abdominal muscles, she's got a very contracted abdominal muscle. This is her normal standing posture. She has a very, very severe amount of abdominal tension here, and it flattens her lumbar spine. So if you do this, if you try and contract your abdominals as tight as you can, sometimes it gives you a flattened back. So if you try and really squeeze in and almost flexing at the waist, it flattens your lumbar spine. And we talk about that again in the pelvic correction webinar. Okay, here, this is very interesting. Look at knee posture. Now, I've drawn arrows on this. These two ladies here, they are really contracting their quadriceps muscles, and there's a little, quite a lot of tension here at the knee. And in fact, the lady on the left here has anterior knee pain, and one of the reasons is because her kneecap has been forced against her underlying structures because of the way she stands. This gentleman here has a knee flexion posture, and you can't see it very well, but if I draw over, can you see that? I try to draw over. This is his left knee is in the background, and his right knee, that is actually the outline of his right knee there. So you can see that the two on the left, they're not fully hyperextended knee postures. These are not examples of full hyperextension, but the lady on the far left, that's more hyperextended than the one in the middle, and both of them are slightly more extended than the man on the right who's standing in knee flexion. The reason you can't see that he's in knee flexion very well is because he's got a very swollen knee, so the back of the knee doesn't look that flexed. You look at their overall stance and just get a general feeling for how are they standing. And again, sometimes this is more apparent in one view than the other, and I'm going to show you that now. So there's a lot to look at in the front view, but again, I tend to do that not in too much detail, and I don't want to labour it because, again, some of you may find that it's a bit impersonal if you're standing in front of your family and friends doing this. But some things to look at are the sternocleidomastoid muscles. So do they appear to be prominent as they come down onto the sternum? The scalings, I'm going to show you a picture of scaling of the clavicles in a minute. And ask yourself, is there an increasing tone? So when you look at yourself in the mirror, go and take a picture of yourself in the mirror, and do the muscles on your neck look the same on both sides? Are they more toned on one side than the other? The clavicles, I'm going to show you another picture on the next slide. I'm going to add to this slide. If you draw lines over them, again, with a crayon, it can be very helpful. So the lady at the top here, the clavicles are actually almost symmetrical, and that's not what most people's clavicles look like. It's because she's hypermobile, so that she's got laxity in the joints, so her joints don't hold her clavicles in the normal posture. This gentleman here, his clavicle on the left of the picture, which is his right clavicle, is more like more commonly seen. The clavicle on the left is actually a bit raised. I couldn't quite see it on the photograph, and I would need to, again, combine this with some palpation to determine where high as I've drawn it, but it definitely wasn't as symmetrical, symmetrical with the other side. And again, this is where it's really useful to look at people from all views, because this is the gentleman that you've seen other pictures of from the back, where we looked at he's the one where I talked about muscle tone. And if you look at this left side of his body, which is on the right of the picture here, look at the shape of the shoulder here, and you can see that there probably is a higher shoulder on one side because the clavicle's raised on that side. And again, here he is here, and if you look at the alignment of him, here's the head, the torso, and the pelvis. You think, yep, lovely, perfectly aligned. And this is what I think is a lot of fun. When you look at a line down the middle of him, at first sight, and you just got to bear with me for a minute, because I'm going to show you another picture. If you drew the line down the middle of the torso, it looks like he's perfectly aligned, but that's not where you position a plumb line in the front view. If you look at the plumb line where his ankles are, it's in the wrong place. When you put a plumb line down, it should be equidistant between the medial malleoli. It should be in between your ankle bones. So if you start at the bottom of the first picture, his front view, you see where that plumb line is that's correctly positioned. Now if you look up, look at where his head is. And it's the same in the back view. If you put it between, now look at where his head is. Can you see? It doesn't bisect him. He's actually got more of his weight on one side than the other. And if I was to guess about this, where would you guess he's positioning his weight? Is he sort of leaning more to the left-hand side? So he's leaning away from his right-hand side? I don't know, but that's quite interesting, isn't it? And why might he be doing that? Why is he putting more weight on one leg than another? Maybe he isn't, I don't know. Have a look at any swelling again. You've got to look at the whole body. Again, you've got to be very careful, haven't you, with people with swelling, about why they might be having that swelling. And in this gentleman, this is due to a heart and lung issue, but particularly a heart problem. And this is a different gentleman. And again, is it edema in the feet? You know, what's causing that? Does he have any underlying conditions? Because certain types of swelling are indicative of other conditions that could be prohibitive for example, massage for hands-on therapy. So you have to use that as part of your history taking. Any geniverum, any bow-legged or knock knees, or any bowing of the tibia, you know, and again, you can't do anything about a bowed tibia, but it might explain why that person walks a certain way or why they have knee pain. And if you think about this image on the right, I've drawn some very faint lines. This is an genu valgum posture. So this gentleman with an osteoarthritic knee, he's got a slight bowing in of the leg there. You can just about see that. Again, look at this gentleman here. Look at this, areas of hypertonicity. Where's their increased tone? Can you see on the right leg, increased tone here? You might want to go away and think about which muscle is hypertrophied here. What might be causing that? I might want to know why he's got more tone on this leg than the other leg. Is it his dominant kicking leg? The previous image, when we looked at his symmetry, suggested that he was weight bearing perhaps more on his left leg. So if he does a lot of football, maybe he's constantly weight bearing on the left and kicking on the right. I don't know. I don't have that sort of information. But this is why we're using this, just to get more information. Again, you could think about the headlights of the knees. You know, you could draw some headlights over the front of the knee. But you could also think about foot position. You know, is this person turning with, if you look at the left image, which is his right foot is turned out a bit. Why might that be? Is it to do with a knee problem or a hip problem? You know, what's going on there? Is it just because that's how the photo was taken at the time? Everyone was just told to stand in their normal posture. They took a few steps forward, a few steps back, and then they stood in their normal posture again. There's lots of information about how you set up a postural assessment and things that you might want to do and avoid in the postural assessment book, but obviously we only had an hour for the webinar, so I'll try to still give you some stuff that you can do. And then finally, you need to think about scars. So this gentleman here on the left, he's got something going down the back of the leg. I'm not quite sure what that is. Is that a scar? What is that running down the back of his leg? This gentleman had open heart surgery, and so there's evidence of an aged scar there. That was from, I don't know, I think it was about 5 years prior to the photo being taken, something like that. So just to finish off, and I'm sorry I've run over a little bit, I've gone over sort of 10 minutes, we'll probably end up another sort of 5 minutes over or so, just some ideas to help you get good at doing postural assessments. Practice on yourself, have photos taken of yourself, that's a really good thing to do. Practice on images from the internet, so just download some images. It could be, you know, dancers are quite good to take pictures of, but of course they tend to be quite symmetrical. Use your family or friends, you know, to practice on, and if they don't want to stand there, maybe just ask them to have some photos. Obviously, again, you've got to be careful with who has access to those images. Practice with a colleague and discuss what you found with a colleague. And again, you could practice on the same person using different methods of recording your observations. You might not want to use a chart, you might want to just take some photographs, or you might want to make some handwritten notes. Again, you could really take your time. You could spend, you know, a long time doing this and focus on it, or you could try a super fast assessment, 2 minutes. What's really standing out at me? What are the key things I have to look at? Or you could just focus on one body part, like you know, the neck or the knees or the hips, something. Or you could focus on just the back or the side or the front view and trying to get good at one particular image. Oops, I'm not sure what's coming from here. I was repeating them. So how do you use your postural assessment to attract clients? This sort of is tying in with trying to get you, if you're not doing it yet, to do some of it. Lots of people are interested in their posture. Now, in my experience, people who've got desk-based jobs or people that use their mobiles a lot, we don't know if there's evidence for these people having, you know, a so-called poor posture. We don't know because there's not enough research on it. But in my experience, they're very concerned about their posture. They tend to think it's giving them bad posture. And so what you could do is you could consider a specific client group, or if you know you've got certain clients that are concerned about it, you could perhaps say, well, this month I'm going to be doing neck assessments, and I'm doing a 15-minute neck assessment on all my clients, and if you book in with me, you'll get a 15-minute neck assessment. And that way you're going to learn a lot and they're going to learn a lot. You could decide to offer it for free, or you could decide I'm going to offer neck assessments or, you know, full body assessments as a bespoke service. But as you're getting, you know, used to things, you could say, well, I'm going to do it for the first month, it's free, and then after that I charge for it. Or if you just want to get really, really good, you could just simply offer them all free, you know, off charge. But again, obviously that might impact on your business, and when, at what time you're going to do that, you know, it's going to stop you. You're not going to have, you know, as much fee earning time. I'm really lucky because I, you know, obviously I was a fitness instructor and massage therapist for many years, and I did this quite a lot prior to becoming a physio, and then as a physio, of course, we have to do it all the time. And if you know, you might only do 10, start to be thinking, well, I'm not sure what I'm looking at. But the question to ask yourself is, well, if I've done 100, would I be better? What do you think? Of course you'll be better when you've done 100. And you could come back to some of the earlier ones you did and redo them. It's just practice. It's like anything. The more you do, the better you get. And what I'd encourage you to do is, while it's fresh in your mind, just go and have a stab at it. Have a go, because it is a lot of fun, and you learn lots of things about bodies. Excuse me. So it only gives you one perspective. You'll need to confirm your findings with other assessments, such as the history and the range of movement and palpation. But it does give you a lot of information. If you want more information, you can come into the Friendly Physio group. So basically, you've just got to be it was set up for massage therapists. We've actually now got nearly 2,000 members, and we're really friendly. I run the group. I never have to sort of really just ban anyone from the group. Nobody sells you products or anything like that. If there's something very useful happening, like jobs going, or sometimes someone's giving them, you know, got a massage couch for sale or something like that, I let them post in the group. But I definitely ban people from selling products to you, so there's none of that sort of stuff. And you can ask questions and you'll get lots of different responses from different people, because it's a really mixed group of people. Some are new to therapy, some are very experienced, and they're all different types of therapists. Of course, you could get one of my books, but for example, the postural assessment is the key one here. It just remains me to say thank you for listening. I know I've overrun, and I apologise for that. So I've gone over 15 minutes. But like Heidi says, you'll have time to, you know, you'll be able to watch this back. And I know I talk very fast. I can't help myself because I love giving you lots of good and juicy information. So you could stop this and pause and practice each section of the video if you wanted in your own time. We've got a lot of small webinars coming up, and Heidi will keep you in touch with all of those. So I'll hand over to Heidi.